Hello, everyone, and welcome to this just-in-time education update. Today, we're going to focus on the COVID-19 vaccine. Our goal is to give you clear, honest, and fact-based information to allow you to make an informed decision about the COVID-19 vaccine. As we normally do, latest medical research and expert opinion from our very own public health trained and board certified emergency physicians. To coin a phrase, this is a no-spin zone. I'm joined today by Wake County EMS Director and Medical Director, Dr. Jose Cabañas, Wake County EMS Deputy Medical Director, Dr. Jeff Williams, and Chief Medical Officer for ESO and former Wake County EMS Director, Medical Director, Dr. Brent Myers, and Michael Bachman, Deputy EMS Director for Medical Affairs. Welcome, and thank you all for joining us today. It's mid-December, and the governor has issued additional stay-at-home orders. We're seeing record-breaking cases counts every day, and hospital capacity is getting low. Dr. Cabañas, can you give us an update on what's happening in Wake County and just bring us up to speed on our county's efforts to mitigate this pandemic?
Well, good morning, everybody. Thanks, Don, for putting this together, and thank you for Brent and Jeff for being here this morning. Before we get started, I really want to thank all of you for your dedication and service during these challenging times. It has been a very long year, but I have express gratitude from the community, and on behalf of the leadership and the county and all our community, thank you for what you have done and continue to do for our community. It is very, very appreciated, and we could not be doing the work we're doing in our community and caring for our patients and their families without your support and your selfless dedication to high quality service. So thank you. So just a quick update on the current situation for Wake County. Obviously, and one of the things that you have noticed over the year is the rapid change on guidance and things that have been evolving as the pandemic progresses through the state and through our community. One of the latest updates you have seen, it has been the Department of State and Health Human Services in the state put out a county alert system. And just quickly, this system pretty much is a way to sort of communicate to communities and local health departments on how rapid the spread of disease has been going in their communities. And it has several components to it. So this system, which right now has Wake County in orange status, which means there's substantial transmission of disease in Wake County, has several components. It has a case rate, it has a % positive, and it has a measure of hospital impact. So right now in Wake County, we have a close to a 7% positive cases with a rapid growth in case rate. And our hospital impact infrastructure is low, but we know, because all of you have seen lately the increased amount of diversion hours and increased amount of volume in the EDs, that this is changing. We're seeing more cases in the hospital, we're seeing more cases in the emergency departments, more cases in the ICUs. So the hospital infrastructure is taking a bigger impact now, still manageable, but it's something that we're paying a close attention to, given this data points that we're collecting on a regular basis. This system is being updated every other week, so you will see these numbers within this week being updated by the state and by the local partners. You will see that, as you all know, in our community, compared to other communities in the state and the country, we are seeing a faster pace of rapid growth in cases. And I think that's something that we're seeing across the country, some areas more than others, but we're seeing sort of a faster growth of cases in our community. And certainly that's why you have seen lately the governor add additional restrictions and additional things that he had put in place to try to mitigate this rapid spread of disease in the community. Now, one thing that I want to highlight to all of you as we get into this conversation about vaccination is the value and the importance of vaccination as it gets rolled out across the country. This is the model from Washington, looking at the specific state of North Carolina, and I encourage all of you just to go to this website and look at different models and look at the different impacts and projections across the country, but also for our state. For daily deaths, the red line sort of gives you the observation that has occurred throughout the state. But when we get to the projections, one thing that is important to understand is, and I tried to highlight this with the circle in the slide, is that rapid vaccination rollout, it's a critical stage in our pandemic response. Once we get this vaccination out to the community, with priority for high vulnerable populations, but also for our frontline healthcare workers, we have the opportunity to pretty much decrease this growth, this rapid growth of the curve throughout the upcoming weeks and months. So rapid vaccination rollout is going to be a critical stage in this pandemic response, and it's something that that is important that we understand, given that it is a light at the end of the tunnel. But the vaccination has a critical will play a critical role in trying to mitigate this rapid growth of daily deaths through the state. So there's two leading vaccine products out there, and I think all of you have seen in the news and in all the different media outlets, everything that is rapidly evolving of vaccination and how things has played out. So I'm excited about this because this really will change the game in our pandemic response. There's two vaccine leading products right now, Pfizer and Moderna, and I'm really excited to have the opportunity here for Brent and Jeff to walk us through the data and the science behind these two products.
All right, thank you, Dr. Cabañas. So Dr. Myers, we're going to throw it to you now. Can you give us a little bit of background on vaccines and what's so special or what's so different about the new COVID-19 vaccines?
Sure, thanks very much. And it's nice to virtually visit with some old friends and make some new ones. So thanks again for having me. It's great to be here. Before we get into the details of this slide, I think there's just a couple of observations that we need to make to really, to your point, be in a no-spin zone, to be in a place that we're having an honest conversation. Throughout the history of our republic, we have argued about infectious disease. It is nothing new. I think one of the things that people like to think about is that we're having these tremendous debates about public health, and it's never ever happened before. It's happened since the beginning. So that's number one. Number two is there's a lot that has changed since we first entered this pandemic in March. And we could today spend the rest of the day having true debate about when should we have a curfew, if at all? Should we close businesses? Should we close schools? Should we wear masks? And people of good faith with good data could have those debates, and we ought to have those debates because that's who we are. But I want to, as we think about going through the history and how these vaccines work, make one observation. Regardless of political camp, beginning in March, every person in leadership on both sides has agreed the only way out of this is a vaccine. We can argue about opening schools, closing schools, we can argue all that stuff. But the very first thing the Trump administration did is start Operation Warp Speed, which is in large portion while we're here, and we ought to acknowledge that. The very first thing the Biden administration wants to do is make sure 100 million doses of vaccine are delivered in 100 days. So let's, for the moment, if we can, which is hard in the current environment, set aside all of these other debates and realize that leaders of both sides started with vaccine and still are there because that's the only way out of this thing. What's interesting from a historical perspective is Cotton Mather, who was a Puritan minister that preached about souls burning in the fire pits of hell and the Lord holding you over them by the thinnest of a thread, also said you ought to get inoculated. And that was in 1721. And in 1730, 3% of the people that got inoculated died. And unfortunately, in corners of the internet and other places, the notion of switching from inoculation to vaccination hasn't yet been made. And we made that change, as you'll see in a minute, in 1796. But inoculation really is taking a live virus from a sick person and putting it under the skin of somebody else. And the hope is that you get a mild disease in the person that you're extracting the virus from, and the other person's perfectly healthy and they don't die. But that's not a perfect science, and people died from inoculation because they were getting a true live vaccine. Nevertheless, John Adams got it in 1777. George Washington had every soldier inoculated because there were more people dying from smallpox than were dying from the British muskets. And so he made a decision. Thomas Jefferson got his whole family inoculated, but only after his 4-year-old died of smallpox. So throughout our history, we've looked at that. The good news is in 1796, we changed this concept and we no longer inoculate with live active disease. Jenner was able to figure out just by observation that if you're near cowpox, you don't get smallpox, and kind of inferred what we now know to be the way that you can do vaccine, which we'll talk about in a little bit. But look how long it took from 1796, the first vaccine. It was 1980 before the World Health Organization declared this disease completely eradicated. It took a long, long time. We're going to beat that this time. Let's go to the next slide. We're going to talk about a framework about these vaccines, and I just want to give a word of thanks to these 3 physicians that participated in a webinar online and shared a lot of their data. We did not take any of their slides verbatim, although they said we could, but it was their ideas and framework that we've incorporated over the next several slides. So I want to say thank you to them, and I do thank them for sharing their information. So the first thing is, what do vaccines do? And what they do is they allow you to have victory by recognizing the enemy. There's 3 things that come. One is they serve up a protein sequence, otherwise known as an antigen. The best analogy I know there is that that's the flag of the enemy. It allows your body to know the enemy's coming because they know what the flag looks like. It must come in a non-infectious vehicle. We're out of those days of the old smallpox inoculation, but it has to activate the immune system. That's how it works. So people, unfortunately, today say, I got sick from the vaccine. Well, you did feel sick from the vaccine because your immune system was activated, but there was no disease associated with that. And that's the important distinction. When we look at side effects that Jeff will go over in a little bit, if you think about these 3 things, we're showing a protein, it's a non-infectious vehicle, but it activates your immune system, a lot of the responses from the vaccine become obvious and you can anticipate them. And obviously the goal is don't get sick because your body can respond. Here's just a graphical way of showing the same thing. If we think about those protein sequences as little shapes, and measles has a triangle and chickenpox has a half cross and there's a half circle for flu, if your body's already seen that, then it's already got antibodies ready to respond. However, the green new pathogen there, for the purposes of this illustration, would be the SARS-CoV-2 virus, where the body's never seen that before. And so by the time it mounts an immune response, the infection, or to use the analogy, the invasion, has already occurred and you're already sick. And the goal is to prevent that from happening. This is a graphical illustration of how that worked for cowpox. The surface antigens on cowpox were so similar to the surface antigens for smallpox, and cowpox does not cause human disease. So it meets our criteria for a vaccine. Shows the protein, not infectious, activates the immune system. Since that time, we have done the same thing on variations on the theme for a host of vaccines. Everything that we do up until, we'll see on the next slide, but don't go there yet, but everything that we do has been historically the same thing. We want a non-infectious vehicle to show up a protein sequence to allow the body to know what that looks like so that it's ready to respond to the next. And there's all different ways to do that, but it's all variations back on that old cowpox, smallpox theme. However, next slide, we are now into a very new world. And this way that the Moderna and Pfizer vaccines work is so elegant in its simplicity. Rather than messing around with finding a vehicle to serve up a protein, why don't we just have your body make the protein for us? It's so much cleaner and so much easier. So the scientists, way wicked smart, and I will show you what I know, which is all on this slide, but we know how this works, right? Is we take a messenger RNA and cause the body with its own endogenous protein synthesis mechanism to serve up that protein that we want you to respond to. Then the vaccine is metabolized as normal, goes away. Your body quits making those proteins, but the immune system has already seen them and has responded to them. Absolutely no chance of infection because all we're doing is telling your body to make a certain protein sequence so that your immune system can recognize it. It works great after one. It works really well after this happens twice. And Jeff will go over that in a little bit. But that is what the messenger RNA vaccines are. So the next couple of slides go over some reasons people are hesitant, and rightly so. As Don pointed out at the very beginning, this is a personal and individual decision. So I'm going to go over a little bit of the background here and then talk about what my personal decision is, and then talk about the vaccines that are left in the pipeline before I hand it over to Jeff. So number one is it only took 62 days from the time that we had the protein sequence to the messenger RNA vaccine was made. 2 separate labs made it within 12 hours of each other after 62 days. Amazing story. But mid-July, Moderna had theirs in the morning and Pfizer had theirs in the evening, all on the same day. Worldwide attention, we got plenty of volunteers, right? You didn't have to beat the bushes to get volunteers to enroll in the study. You'll see when Jeff does his talk, there's over 70,000 people that have volunteered just for these 2 trials. There's a good prevalence of disease, which is bad when we think about it from a community perspective, but is really good when you're trying to test a vaccine, because you want to make sure that somebody's going to get infected so you can tell if the vaccine works or not. And then perhaps most importantly, this last bullet has been kind of taken out of context a little bit, I think. An emergency use authorization is not a full release of a drug. And because of that, you don't have to do the testing on every possible population. So you'll see there were very few people under the age of 18 in these trials, and they just started with the 16 and 17-year-olds. That was purposeful because they wanted to move quickly. Pregnant patients, those are to be studied in future trials. Immunocompromised, the list goes on, because an EUA is designed to target the population greatest at risk. And we know for right now, the population greatest at risk are likely not in the pregnancy age and certainly not less than 18. And so we move to do that population quickly, and that allows us to move fast. The other thing that comes out a lot is, well, fine with all of that, but the immunity doesn't last anyway. I've seen that in the media. So you get it, and the immunity lasts a few days and goes away. So what good would a vaccine do anyhow? And I get asked this question all the time. So a couple of things, and we can go over this in question and answer in more detail. I don't want to take it all the time here, but just based on antibody trials, it is very clear there have been about 55 million cases of COVID just in the United States since March. That's just a scientific fact. Most of them have been mild or asymptomatic, but there have been 55 million cases. So if you think about a 1 in a million, it's happened 55 times. And the media has had an amazing focus on this disease. So yes, there have been a handful of people that have been reinfected. There's a handful of people that have this very bizarre reaction, but those are the 1 in a millions. The good news is this virus has not recreated human physiology. As it turns out, the immune system still works like it always has. And if you've been exposed to an antigen, you create memory, and well over 90% of the people have persistent immunity. Now, can we tell you that immunity is 10 years long? Of course not, because the disease hasn't been here but since March. But for the time we can measure, there is a persistent immunity, so the vaccine will work. And that's an important piece. And this is a free article for people who want to go into great detail. This will take you into the weeds of how the immune system works. But suffice it to say, 90% of the folks or greater have a persistent immune response, and that's good news.
And that's true for other vaccines as well, right? I mean, that's why we draw titers and give boosters.
Exactly right. And we know the flu is has the least timeline on this, and it also has the most variation. So you have to get one of those every year. But yeah, some of the others you can go longer, right? Same thing. So I agree here with the Wall Street Journal. The people that developed this deserve the Nobel Prize. The rapidity, the scientific rigor, the safety with which they've evaluated this is just unheard of in the history of the world. That's just a fact. And I want to take this 1 minute here to say how I'm making my personal decision. And my personal decision is I love my family, I love my friends, I love my community, and I love my nation. And there's only one way out of this, and it is to get a vaccine. So for me personally, it's not even a question. It is the first minute it's available. And these scientists that did all of this work, the least we can do is roll up our sleeve and use their invention to get out of this mess that we're in. So I think that's an important piece. So let's go into where we are. This is the vaccine tracker from the New York Times. There's 40 that are way back still early. There's 7 that have some limited use somewhere around the world. The first 2, which are on the next slide, look at the ones we're going to a little bit with Jeff, which is Moderna and Pfizer. So I'm not going to spend any time on those. The next two are the ones to watch coming over the horizon, and that's Johnson & Johnson and AstraZeneca. These two are more of the historical, more common type vaccines where they are serving up this protein sequence on a non-infectious vector. These are not mRNA vaccines. They're taking a little bit longer to develop. And at the moment, while they seem to be very efficacious, they're not as efficacious as the Moderna and Pfizer ones that we've seen so far. The next set, I don't think are coming to the United States, but they are approved for places in the world. So in the spirit of transparency, there are places where you can use these vaccines today. I would be very surprised if they came here. And if they did, they would have to go through the exact same FDA process, which none of them have submitted to do. So until they submit to go through that rigorous process, I don't think we should consider them further, but I do think it's important to know there are others that are approved elsewhere in the world, and these are they. So we already talked about what an EUA is. Jeff's going to go into the details of that. It does give you a safety and efficacy profile, some potential side effects and contraindications. The last slide I want to do is the next one, which is the difference between efficacy and effectiveness. Because I think from a contextual perspective, that's important to think about as we look at these upcoming data. The first is efficacy means we're in a trial. Does it work in the trial population? And if you think about that, those folks are followed very clearly. They have follow-up calls to come get their vaccines. All of those things are done in a very focused, almost sterile environment, for lack of a better term. And you have to do that to see if the thing actually works. If it's randomized appropriately, then an efficacious trial will also be effective, meaning that we've mirrored the population sufficiently in the trial that it represents the population at large. But effectiveness also has to do with the logistics of this thing. Can we keep it cold enough? Can we get it shipped? Will people come for the second dose? So we know, I think, I'm pretty convinced, I hope you will be too after Jeff talks, we know these vaccines are efficacious. The question now is, can we make them effective? And I think folks in phase 1 have the opportunity to demonstrate how to do that by responsibly showing up not only for the first one, but the second one, and proving that this can be done. So with that, I'll stop and turn it back to you, Don.
All right, thank you very much for that historical perspective. And now we're going to bring in Dr. Williams to get into the minutia of all this, and hopefully he can answer the question on everybody's mind: are the vaccines in fact safe?
Good morning, everybody. Thanks for having us and Jose for putting the group together. Throughout my career, I have had to follow Brent Myers speaking. So today is another example of that, but hopefully we'll manage to make it through here. I did want to get into the weeds. I know all of you are terribly surprised that to go through the weeds with everybody on some of the detail. But we are 100% being super transparent about this, and you'll see throughout my talk that we've got links to all of these documents that we're discussing as well. If anybody wants to read them on their own, or if anyone does read them on their own and has further questions that we didn't cover here, please do shoot one of us a text or give us a call or find us in the ER or wherever, and we'll walk you through it as best we know. So. This slide, and Don, you can go to the next slide, basically is just a title placeholder for the information that was presented to the FDA to grant emergency use authorization for the Pfizer vaccine. And as you guys know, that happened this past week on December 10th. So I wanted to talk just for a minute about what is emergency use authorization, and again, kind of reassure everybody that just like we've been arguing about vaccines since the beginning of our country, emergency use authorization has been around for a long time as well, and this isn't something that's new and invented, solely for this situation or anything like that. So emergency use authorization, obviously EUA for short, is authority granted to the FDA to make available a drug. It could be a device, it could be a test, any sort of biologic product that may be effective to prevent, diagnose, or treat serious or life-threatening illness or condition. So first established in 1938 and since reauthorized multiple times, most recently in the setting of a lot of the bioterrorism legislation that happened earlier in the 2000s. And basically the sort of rate limiting step, or the first thing that has to happen for an EUA to be granted for any reason is that somebody in charge of one of our cabinets, either DHS Defense or DHHS, must declare that there is an emergency, right? In this case, a public health emergency that DHHS has declared, and then you can sort of move forward with the EUA process. And as Brent mentioned before, it's important to realize that EUA is not full FDA approval. The standard for EUA is that a drug device test may be effective and is not as high of a standard, frankly, as full approval. Now, that said, there is a very rigorous risk-benefit analysis that EUA uses that is based on, quote, the totality of scientific evidence available, right? So people aren't picking and choosing. This isn't, something where people are looking at sort of only the good results, if you will. But drug manufacturers and those that would review the data on these drugs, vaccines in this case, must use the totality of the scientific evidence available. The real difference between EUA and full FDA approval is that full FDA approval requires, quote, substantial evidence. And without going too far into the weeds about what that is, it basically just means more studies, right? So more studies and not necessarily more time. As Brent mentioned, we all should be very excited about Operation Warp Speed and the fast laser focus that people put on this process, right? There weren't relaxed timelines. There wasn't, hey, let's wait another year for another study on whatever drug that might be important, but isn't as important as this vaccine. It was, we're going to do this now, and this is going to be a focus for our agency, and this is going to be a focus for drug makers, and we're going to get it done quickly. And then lastly, I just wanted to say EUA is in place right now for a lot of things that would apply in our world, right? So Ebola antigen test is available under EUA. There is a certain type of freeze-dried plasma and the process they use to freeze-dry that plasma that our military uses right now. It was developed in Europe, and for it to be able to be used in the U.S. for our military without full authorization, they have an EUA. And then actually atropine auto-injectors, similar to the ones that we carry, right, for nerve agent use, are available under EUA, a specific type of auto-injector, a specific dose and formulation. So there's a lot out there that we use today, and EUA shouldn't be something that's worrisome or scary. So what's the history on EUA for this process? February 4th, 2020, the HHS secretary declared that emergency that we talked about that's necessary. Again, laser focus on the vaccine versus usual timelines. And this was how we were able to get this done quickly. That said, I want to make it really crystal to everybody that there were no corners cut in terms of how these vaccines were developed compared to any other drug. So again, without going into weeks worth of details, drugs are required to have phase 1, phase 2, and phase 3 trials before they are even considered for either FDA approval or EUA. All 3 phases of trials were completed for these vaccines. Moderna and Pfizer happened to sort of win the race as far as getting them done and getting their data analyzed. But I want to reassure everyone that phase 1, phase 2, and phase 3 trials were completed for these vaccines. In fact, we'll actually talk about the phase 1 trial for Moderna here in a few slides. So what happened next was, again, last week, the FDA has an independent vaccine advisory committee that basically votes to recommend whether the FDA should approve for EUA a vaccine or a drug. That happened on the 10th, and the FDA, obviously, these slides I made on Friday, and obviously a lot's happened even since Friday. The FDA over the weekend accepted that recommendation, and then the CDC also basically said, yes, we are willing to accept the FDA's recommendation, and these vaccines that are getting shipped around the country at this point, we think that it's a good idea that the American public should receive those shots. Is the bottom line on that. And Don, you can go to the next slide.
Before we go, I think it's important to point out that the Vaccine Advisory Committee covers all vaccine. It is not just specific to the COVID-19 vaccine. This isn't something that was just created. This committee just wasn't created for COVID-19. That committee's been around and makes their recommendation for all vaccines.
Yeah, very good point. Excellent. Absolutely. So what basically, the drug manufacturers and the FDA does at its advisory committee meeting, and obviously, associated analysis, is they try to figure out two things. Is the vaccine safe? And is it efficacious, right? Does it work in study conditions, as Brent pointed out earlier? And so we want to talk about the safety and efficacy profile of specifically the Pfizer vaccine, because that's the one we know the most about at this point, but a little bit also about the Moderna vaccine in terms of what we know so far. Safety simply means how many unexpected adverse events versus expected adverse events happen with a given vaccine, right? So when you study a population of 30,000 people or 40,000 people over a period of time, whether that's a short period of time or a long period of time, unfortunately, bad stuff happens to those 30,000 people, right? Some of them going to die. Some of them going to have a heart attack and die in the middle of their drug trial, right? Other people are going to get hit by a car, right? There is, believe it or not, and I'm getting a little far in the weeds here, there is a description of a facial fracture adverse event due to an assault to a vaccine trial participant in the Pfizer minutia. And they had to do an analysis of whether or not this guy got assaulted as a result of receiving either placebo or true vaccine in the Pfizer trial. So the point is, bad stuff happens to people whether you're in the control group of placebo or whether you're getting the vaccine. And the job of the scientist is to figure out whether or not those adverse events are likely related to the vaccine or not, and or if they can't tell, do they occur in a number that is more substantial in one group than another, right? That's how you sort of do that analysis. Efficacy, not to repeat too much of what Brent said, basically just means the performance of the vaccine. Did it work as intended? And a lot of this data, or really the detail of this data that we know about, was that first title slide that Don showed for my part, which is the briefing document, the 53-page briefing document that all of us have read in every word for that Pfizer BioNTech EUA meeting that happened on the 10th. Don, you can go to the next slide. So this information we're about to go through comes from that briefing document. So let's talk first about safety, right? So we can't move to efficacy if the vaccine's not safe. We have safety data from about 38,000 participants with a median of 2 months of follow-up for this vaccine. Adverse events, just based simply on technology, that could possibly be linked to receiving that vaccination shot, generally start well within 6 weeks, usually within a few days, potentially, of receiving the vaccine. So FDA feels like, 2 months follow-up, while relatively short, is an appropriate follow-up time to report these safety data. And again, we're talking about serious adverse events for participants. We look at every case of appendicitis. The scientists look at every case of MI, every case of stroke, every case of death. There were some in both groups. Those obviously were very small and unrelated to the vaccine. What we call solicited adverse events are what people are probably more familiar with as side effects, right? So these are expected things, right? So I know I joke around with some of you guys every year when I get my flu shot. I am one of the unlucky fraction of people that have a little bit of an immune response that I'm frankly proud of, right? I take my Motrin and I get my flu shot and I ache for a day or two and, whine about it. And these guys make fun of me. But the point is that is evidence of your immune system working, right? Building antibodies to whatever medicine is that you just received, right? And so these are solicited adverse events. We knew going into this that if you inject a vaccine into someone, some fraction of those people are going to get injection site pain, are going to get fatigue, are going to get headache, chills, muscle joint pain. And so you want to know, sort of the fraction of the time that occurs, one group compared to the other. And then also, are there anything that's unexpected? Really, the only thing that was kind of interesting about the Pfizer vaccine was that there were 64 cases of swollen lymph nodes, right? So people got a little bit of lymphadenopathy, just like you might get with a sore throat, maybe a little axillary lymphadenopathy like you might get with a viral syndrome. That was really the only thing that they sort of said, typically we don't see a ton of that with vaccines, but that was obviously minor and self-limited. So here's the punchline. This is the primary outcome for the phase 3 trial that Pfizer presented to the FDA. So what you see there is 2 red circles. And at the very top of the table, column 1, you have about 18,000 participants. Column 2, you have about 18,000 participants. And that first group is the vaccine group. in the first column, and the second group is the placebo group. And the punchline is that in the vaccine group of the patients who actually received COVID vaccine, only 8 patients got COVID. On the flip side, 162 patients who were in the placebo group got COVID. So that's how you hear in the media about this 95% efficacy, right? You do the math, and that turns out to be a 95% efficacious vaccine. Important to note that they also looked as a secondary outcome severity of cases of COVID. One case was severe in the patients who were vaccinated, and 9 cases were severe in the patients who received placebo. Don, you can go next slide. And I'm going to ask to see if Brent or Jose or Don has any comment on this slide after I go through it. It's a little bit detailed, so I want to make sure I don't leave anything out. But this to me is striking and a good graphical representation of the efficacy of this vaccine. So what you're seeing is a survival curve. Is sort of the name of the graph, but it's not about life or death in this case. But what you see across the x-axis, across the bottom, is basically time, right? Time counted in days. And then what you see on the y-axis, which is represented by each one of those little squares and circles, is a case of COVID. And the cases sort of count. They stack up on top of each other over time. And so you see over a period of time who got COVID based on those little stacked squares and circles, right? So the blue line with the blue circles is people who got true, real deal Pfizer vaccine, and the red line and the red squares are the people who were in the placebo group. So you see over this median of, approaching 120 days, that the blue line and the red line track together, and this is days after dose 1, days after day 0, which is vaccination dose 1. The blue line and the red line track together until right about day 10, maybe day 14, and then the lines start to diverge. This makes complete sense based on the fact that if you get vaccinated on day 1, it's going to take your body a few days to build up immunity, right? You still got to wear your mask right after you're vaccinated for sure. And start building those antibodies. And then right around day 14, when your body's got plenty of antibodies, those lines dramatically diverge. And people in the placebo group still accumulate cases of COVID over time, whereas people in the placebo group do not accumulate those cases over time, right? And as Brent mentioned before, there's plenty of data to suggest that there's no waning protection, at least over the follow-up time that we know about so far. Guys, any other comment or thought on those?
Yeah, Jeff, I was going to say this is to me one of the most important slides, and it's one of the importance. If anybody wants to take a look at the FDA handout that was presented to the committee, that is actually public, it's like a 50-some page document. This is one of the most important content of that handout that was evaluated for all data. It summarizes the striking impact and efficacy of this vaccine, and how both groups are marching together. You can see a clear split off at that day, sort of 7-10 right there. So I think that to me is actually very striking. I think it's something that it's a visualization of how valuable this vaccine is. It's pretty impressive. And while we've been recording this video, Jeff, I just posted in the chat that the first vaccine was given in the U.S. Already this morning. So we're going to turn the corner hopefully soon, and we're making progress.
And Jeff, just one other thing to throw in there, because I know that we have a great group that is very into the weeds and counts data, and we're glad that they do. If you start counting those blue circles, there's going to be more blue circles than there were on the previous slide. And the reason is, remember, the trial was that you started counting cases at the 21st day, right? So there are some cases even after the split that are not counted in the trial because they are advertising that the vaccine is not efficacious until, if I've counted right, I think it's day 28 on this graph is where they actually cut the data. In other words, they were not advertising that it was going to work before that period of time. So even though you see the split occurred earlier than they thought it was going to, honestly. But if you start counting those blue circles, there's more blue circles here than there were on the previous slide, and that's why. The other thing to keep in mind is Moderna counts 7 days even farther. So when you see the Moderna results, they waited to what would be day 35 on this graph to count their results. So I know that people want to be very precise about their data and make sure that all is transparent. And I figured somebody would count those up and figure out the numbers weren't right, and that's why.
Yeah, absolutely. Totally related to how they're defining their endpoint, their primary endpoint. And again, you can slice and dice this a lot of different ways. Don, thanks. And you can go to the next slide. So just real briefly, I want to go through a little bit about what we know about Moderna. So this week, 1 week after the Pfizer meeting is going to be a very similar meeting for the FDA for the Moderna vaccine. We don't have as much data right now available to us or to anyone on the Moderna vaccine for that reason, right? That FDA meeting hasn't happened yet. We do know phase 1 data from Moderna, as that was published in the New England Journal. That is a free access article. Anybody can get that and read it if you want to. And what we do know about phase 3 information on the Moderna vaccine was based on a news release. And so we all saw that, we all reacted to that. And basically, they're presenting similar information to what we know about Pfizer, which is of these thousands and thousands of people that were studied, how many cases of COVID occurred in the group that got vaccinated versus how many occurred in the group that got placebo. It's a similar technology as the Pfizer vaccine, as Brent had already mentioned, and likely there is a similar efficacy and safety profile, but we won't know yet until we take a look at those data later this week. Don, you can go to the next slide. So in the Moderna trial, one thing that was a little bit interesting was that the phase 1 trial actually showed only half those participants started to develop antibodies after the first shot. Both of these vaccines require a 2-shot series, as Brent pointed out on the prior slide. That's how they measured their overall efficacy for the trial. This just tells us potentially the importance of both doses, regardless of which vaccine you get, right? So in the Moderna data, it may be the case that there's a little bit less immunity conferred after the first dose than compared to Pfizer, but it would be speculation to say so far. The point being, take both doses if that's what's recommended. And again, the phase 3 information on Moderna based on that press release were that 185 patients in the placebo group got COVID versus 11 patients in the vaccine group. And one thing that was notable, again, there's confidence intervals around this, obviously, but zero severe cases in the vaccine group for Moderna, which is pretty impressive. And again, based on the press release, the side effect profile is likely similar to Pfizer, and I believe that's what we're talking about next. Yep, so potential side effects. So these side effects are all listed in a table. I know that's probably hard to see. Maybe you can get in close to your computer screen there, but these are all in a table on the FDA briefing document. And, it's just hard to kind of ballpark. I heard one person that I trust say, for most people, it's probably going to be a little worse than the flu vaccine, but not as bad as the shingles vaccine. I haven't had the shingles vaccine. I don't know. But bottom line is you're probably going to get a little bit of an immune response, probably more likely after the second dose of either vaccine. And if you're somebody who gets one already when you get the flu, take a little Motrin, take a little Tylenol, whatever you want to do. But this is something that you should basically expect. I want to point out that a lot of the press and media about this has sort of reported the frequency of certain complaints after the vaccine in the vaccine group. I think it's important to note that people in the placebo group also report side effects, which has always been interesting to me, right? But people are walking through life with a headache and, fatigue and fever, occasionally, and that's fine. It ain't related to the vaccine, and it's probably more reasonable to compare sort of the difference between the two groups than, sort of the singular rate of symptoms in the group that got the vaccine. So, for example, shortly after getting the vaccine, 47 people in the vaccine group, after getting their injection, 47% of people in the vaccine group versus 33% of people in the placebo group reported that they were tired. Well, guess what, friends? It's 2020. We're all tired, right? So, I'm not 100% sure we need to worry about 47% of the people in the vaccine group reporting fatigue. Headaches, similarly, fever, and sort of on down. Obviously, things like fever, they're going to be a bigger difference between the vaccine group than the placebo group, but nonetheless, it's important to take a look, I think, at both columns. And I just want to reiterate, I think this is super important. I know we already said it, but you cannot get COVID from this vaccine. You can't get whatever the disease in question is from any of the vaccines, but specifically for the mRNA vaccine, there is nothing close to COVID anywhere in your body, right? So what this little liposomes are doing, which is the delivery vehicle for the mRNA, is injecting blueprints, right? It is putting a set of building plans into your cells. The construction mechanisms of the cell are nowhere close to the nucleus, nowhere close to your own DNA, and those little builders in your own cells take a look at those plans and say, okay, we're supposed to build this protein. And they build a protein that looks like the spike protein for COVID, which is how you get antibodies to it, but it is not anywhere close to your DNA or your body's genetic material. So people want to talk about Pfizer versus Moderna. Should I get one? Should I get the other? Does it really matter? I will tell you that I will personally roll up my sleeve for whichever one is offered to me first. It may be the Pfizer vaccine. Wake Med is probably my first avenue in for the vaccine, if not Wake County Public Health. And if it happens to be the Pfizer vaccine and I'm offered that, this week or next week, sign me up. If I'm allocated to a little bit of a later group and it's a week or two from now and Moderna happens to be available, sign me up, right? There are really not a ton of differences based on, number one, the very similar technology. There are a couple of practical considerations that may be worth talking about. Cold storage. The Moderna vaccine has to be kept slightly less cold than the Pfizer vaccine. That probably has to do with the stabilization of the delivery vehicle more than anything else. It's possible that the Pfizer vaccine might induce a greater immune response after one dose. We don't know that. It's possible, based on number of severe cases, that Moderna prevents more severe disease. But that's, those are pure speculation, right? Pure speculation based on the data that have been presented to the FDA so far. And I want to reiterate the point that both of these vaccines are very efficacious, very safe, and all of us should take whichever one is offered to us first. In terms of contraindications, Jose wanted me to cover contraindications, and I think probably a better way to talk about it is sort of unknowns. There are not really a ton of contraindications to any vaccine at this point per se, in that immunocompromised people, in theory, should probably all get vaccinated. However, they haven't really been studied yet, right? Children, if I could give the vaccine to my kids tomorrow, I would, absolutely. But there haven't been enough children in the trial yet to sort of have that level of evidence available to the FDA. So duration of vaccine effectiveness is unknown. Vaccine effectiveness against asymptomatic carriers is unknown. I think that's one important thing to talk about. Both the Pfizer trial and we believe the Moderna trial looked at defining a case as a case with symptoms plus a positive test. So it wasn't just a positive test. So one thing we don't know is the vaccine as efficacious against asymptomatic carriers as it is against people with symptoms. And so there's no science to think that it should be otherwise. But it is possible that if, for example, the vaccine was less efficacious in asymptomatic carriers, then that would have an effect on transmission. That said, the fact that cases occurred at a much lower rate in the vaccine group shows that transmission is likely impacted. So I guess in summary, the technology surrounding teaching our body to make antibodies against these proteins has really been around for years. I've got friends in my neighborhood. A guy runs a lab over at Duke on neurodegenerative diseases and trying to develop drugs for things like Alzheimer's and such. They've worked with mRNA technology and tried to make it work for their drugs. This is not something new. This is part of the reason why we were able to get it developed so fast for this particular purpose. we were able to get it developed so fast because of Operation Warp Speed, because of the public-private partnership, because of the laser focus of the FDA and drug makers on getting this done to get ourselves out of this pandemic. The EUA process is a rigid, reliable, appropriate process, even though it is quick. It has been around for a while. The vaccine safety and efficacy profiles, certainly for Pfizer and probably for Moderna and the others, are very reassuring. And, you know, I think the last thing to say is this isn't over yet, right? So they're going to be looking at these vaccines for a long time and try to make them as perfect as possible. And we'll obviously be paying attention to that and reporting on those data as well.
All right, now that we have a good understanding of how vaccines work and the process in which the COVID-19 vaccine was created, I want to bring in Chief Mike Bachman here. Bachman, can you tell us, you know, how the vaccine is going to be rolled out? I understand there's going to be a couple of stages, and who made that determination of, you know, what category of people went into what category, if you will?
Yeah, let me show you and understand this is changing a little bit as we're putting all this together and with some most recent updates. So let me share a couple slides with you that I think will help pull all that together. Okay, so this is all done through the Federal Pharmacy Partnership for COVID-19. So there were several pharmacy partners that were going to be receive direct allocations of COVID-19 vaccine. And Wake County Human Services will be one of those, in addition to some of the area hospitals throughout the state, as we speak about North Carolina specifically. So what's happened is that there is a 3-phase plan, and I'll show you what that plan looks like here in just a minute. For us, the important part is that frontline medical workers, to include EMS, are included in what's called Phase 1A. So there's Phase 1, and it's broken up into Phase 1A and 1B. And then as more vaccine is available, as distribution expands, then they will start ramping up all of those other phases of the vaccine. And I'm sure we've all seen all of the things on the news media about how much is being produced by the various manufacturers. And it depends on how much, and once we meet some of these, meet one need, then they're going to be ready to roll out to the second one. So this is just sort of a little bit of a graphical display of who gets it as we look at available doses, and to kind of go through. And obviously we're in Phase 1A, which is the top left. And remember, that's where we have a shorter supply, if you will. So back to kind of your original question, there was the CDC Advisory Committee that went through and refined the input by North Carolina Institute of Medicine to look at who fits into which category, which phase, and who gets those. And this is just another look at that with the Phase 1 and A and 1B, and then Phase 2, Phase 3, Phase 4. So we can sort of see that while there are some people that look like frontline workers that will fit into some of these other phases, it's also contingent upon them having 2 or more chronic conditions to fit into Phase 1. Otherwise, they become a later piece globally in one of the later phases. So some of our public safety partners, for instance, if they have 2 or more chronic conditions, then they fit into part of Phase 1. If they don't, they'll fit into a later phase. So I think that's important. And I think that as the other folks on the video talk about, you know, what the vaccine is and all of those factors, understand that the vaccine is available for us now. How that works if you decide I don't want it right now, I want it later, can you just get it at any point versus you have to wait until a later phase where it's opened up larger? I think some of those questions are still being answered. What we know is that if you qualify today, when Phase 1A starts, that is your earliest opportunity and best opportunity to get the vaccine when it first comes out. So it's sort of a little bit of a complicated rollout, if you will. So the week of December 14th, we know that there's going to be the first round of distribution of the Pfizer vaccine, but it's only being released to the hospital. So we are not going to get any of that vaccine through Wake County Human Services as we know today. What our anticipation is the week of December 21st, the first round of vaccine will be delivered to Wake County Human Services for distribution as part of that 1A, which EMS will fit into. Now, originally, as we talked about Pfizer being released on the 14th, now this is all contingent upon all the federal regulatory stuff going through as planned. When the week of the 21st happens, there is a potential that we would get the Pfizer or the Moderna or a combination of of both released to Wake County. This is one thing about the supply chain. Until it's time for the release, you're not really sure which one or how much of that vaccine that you're going to be getting. So you sort of get what you got at that current point in time. The last question I asked, even as of this morning, to get some more clarification is, let's say that both vaccines are available. And they're available through Wake County Human Services, and you say, well, you know, I want one, but more so than I would like the other vaccine, based off of the information you've heard. We're not sure that you'll have that opportunity. I think that it will depend on the site that you're allocated to go to receive the vaccine, how much of that vaccine is available. So clearly, if everybody says, oh, I only want vaccine B of the two, well, there may not be enough of that. And so you may not have that choice. So I just want to kind of put that out there, that we're not sure that even if both are available, that you will get a choice as to which one that you will get. Now, as we all know, both of these vaccines require 2 doses. 21 days for the Pfizer, at least 28 days for the Moderna, is the last that I understand those to be. We're also working with Wake County Human Services to figure out how to vaccinate people. How do we do that? We also know that, just like with any vaccine, there may be some post-vaccine administration minor symptoms that you receive, and you may not feel well. I know that as we rolled out flu vaccine this year, a lot of people said, hey, you know, I want to get that at the end of my cycle so that I don't feel bad. I've got a couple days to recover. We want to keep that in mind as well, but also understand that we're under a much tighter time crunch, because unlike flu, where they give us the total amount of flu vaccines we need for the year, they're only allocating a certain number of vaccines. And once those vaccines, it's not the total number that are going to be allocated for that particular pharmacy, it's just a small amount. Once they've administered those, they can get a resupply. So instead of getting it all at once, they're going to get it in segments. So we're going to be under a tighter time crunch. So there will be a schedule, and you have to come during that scheduled time to get it. We won't be able to say, you know, I'm going to wait a week or two. That likely won't be available to do that, to be able to stay on track and to manage the vaccines that we're getting. The other part that Human Services is primarily responsible for, but we're going to figure out how to work with them to help you all coordinate, is, again, there's a 21 or 28 day redose cycle, and how do we help you remember when that is, and how do we plan for your second dose? So we're going to be working with them to help coordinate that as well. So Don, that's just a little bit of overview of where we got the vaccine, where EMS fits into the vaccine, and our tentative plans to how we're going to administer that. And understand it's a very dynamic process. A lot of the kinks are still working out. So, and again, a lot of it depends on exactly when that first shipment arrives.
All right, so up next is going to be question and answer time, and I have sheets of questions about things that I have heard other people ask, things are on the news. Dr. Cabañas, I want to start with you. For Wake County employees, will this vaccine be mandatory?
No, at this time, there's no specific policy that mandates that every employee needs to get a vaccine. And the reason we're doing it that way is, number one, this is under the EUA approval, so this process is still sort of evolving. And number two, I think the biggest value is to make sure that we're providing everybody with all the information and education necessary so people can make a personal choice. So at this time, there's no guidance or direction to make this mandatory. Our efforts are not going about that. Our efforts are about making sure that we're giving you all the education and the information you need to make sure you can make a personal choice of a vaccination. And from my point of view, I am going to get the vaccine as soon as possible. I'll be the first one online as soon as whatever is available. It is in my view, is the right thing to do as a clinician, protect my family, protect my patients, and protect my community.
And for those who get the vaccine, whether or not they're a Wake County employee or not, is there a cost to getting the vaccine?
No, there's no cost for the vaccine as part of the Operation Warp Speed development and all the efforts that you're seeing in coordination between federal, state, and local. The goal, the primary purpose is to make this available as broadly as possible across the country, so we can actually have a dent in that curve for the pandemic.
And this can be for anybody. We talked about the fact that children were not in the test group, neither were pregnant women. So if we have a female who is nursing or currently pregnant or trying to get pregnant, should they get the vaccine?
Based on the current evidence, that has not been evaluated, right? So I think Jeff put it exactly right. It's not a contraindication, it's an unknown, right? We have not tested in that population. Now, is there any reason to think there's a problem? No, but it's not been tested. So, that'll be between you and your OBGYN, I would think. I mean, the EUA is like anything else. Once it's in the wild, you can kind of do what you want, but I would certainly not recommend it as a general course.
Right.
Yeah.
So go ahead, Jeff.
I was just going to say I agree with that. I think that there's no reason to believe that it's not efficacious or dangerous in any of those populations. Again, if I could drag my children down to the pediatrician and get them vaccinated with the same shot that I'm getting vaccinated with, I would absolutely 100% do that. But from a ethics and science standpoint, the reality is that if we're saying transparency and the importance of this process on one side and then subverting the process on the other, those two things don't really jive. So I think because those groups are not in the EUA, unfortunately, we're going to have to wait for more information and more data before we can recommend it.
Yeah, and I think I agree with that 100%. I would say that I would recommend, obviously, for anybody who, children, patients, are pregnant, I think a conversation with a primary care physician or OBGYN physician, it's actually highly recommended because, like Brent and Jeff stated, they haven't been studied, so we really just don't know. But we have a very low suspicion that has any major side effects or anything like that. So I will vaccinate my children, but I mean I would recommend that everybody sort of have that conversation with their own primary care provider for those populations.
Similarly, if I've already had COVID-19, I've had a positive test, do I still need to get the vaccine?
Yes.
Yes.
Yep.
For the reasons in that study, right? There's 10 to 15% of people that don't mount on a response, and it's hard to know without a whole host of very in-depth testing whether you were in that group or not. So it's easier just to get the vaccine.
Yes.
So the vaccine itself, one of the endpoints of the study, the vaccine's not designed to kill the virus. Is that correct? Okay. So if it's not designed to kill the virus, and I'm relatively healthy, right? I don't have any of the, comorbidities that put me in the high risk group. And I know I'm still going to have wear a mask after I get the vaccine. And we're not sure how long, the vaccine will last. Do I still need to get it?
Yeah, and I want to just go back to what you said originally in terms of kill the virus. I'm not exactly sure what you mean by kill it. So the vaccine is designed to identify the protein on the outside of COVID and then get rid of it, right? Get it out of your body. You can say kill it, you can say remove it, you can say whatever you want, but your body's, you at that point have antibodies floating around your body in your bloodstream that would recognize a COVID virus particle when it came into your body and get rid of that, right? Break it down, remove it, get it out of there. So you can say kill it, you can say remove it, but yes, absolutely, the vaccine makes antibodies against the COVID virus. So the vaccine itself doesn't kill COVID, but right. The results of the vaccine is that your body is able to kill COVID, right?
Yes.
So I think that's an important distinction because the back end of the answer to the question is, even though we're pretty far into this pandemic, and 2020 feels like a really long year to everybody, there's still a lot about this virus that we don't know. It does have a very high death rate, despite what you may have heard or read. And we also don't know exactly how it affects certain individuals, right? So some young, healthy people get COVID and die, right? That's a true fact. Some older, sicker people, probably more older and sicker people, fortunately or unfortunately, get COVID and die. But people have bad outcomes and long-term hospitalizations and morbidity and mortality from COVID. And it's hard to predict who those people will be. And those people who get COVID and have either significant symptomatic illness or, long-term hospitalization, ICU, or even death, those folks are occurring in the population at a higher rate than for other viruses that we know a lot about. And so, I think it's important to be able to sort of trust your own body's immune system to battle various and sundry viruses and bacteria. But there is no reason why we shouldn't be looking for the extra boost that the COVID vaccine gives us to create antibodies, so that those antibodies can then, kill the virus when they see it, as opposed to starting fresh, right? It's like running a marathon, but instead of starting at the starting line, you get to start halfway through, right? Why would you not give your body a chance to start halfway through when it's battling something like COVID?
And I want to give it a different view, which is, yes, that's all that is. I agree 100%. That has to do with the individual. For us as a nation to get out of this thing, 70% of the population at a minimum has to have immunity. It may be higher than that, but it's absolutely 70%. And, there are states, and it's fine to name them because it's a public thing, New York, Colorado, and soon Alaska, that are considering removing EMS from phase 1A.
Yeah.
Right now in North Carolina, we are very fortunate that our leaders understand how important it is to leave EMS in 1A. So I think the reason they're doing that is, of course, because they care about the health of the individual, but it's also because from a public health perspective, we need the EMS and frontline health workers healthy and available between now and April. And so I think there's an individual piece that you talked about, but there's also this larger community calling, if you will, that says, we know this thing's safe. I mean, look at the side effect profile is pretty benign. I mean, all things considered. And we know we need to get to 70%. There's only one way to get there.
And I would add one thing, Don, real quick to add is, and if you, and I'll let also Brent add here, but also consider the strategy of, on the first phase of the vaccination rollout process of first addressing the vulnerable populations and frontline workers and folks in the front lines translates into more lives saved, right? Because you're that's the high risk population, and by you vaccinating and doing that first, when you look at some of the models out there, there's actually more lives saved over time from a population level standpoint.
Yeah. A slow rollout saves about 25,000 lives, according to the University of Washington, between now and April the 1st. A rapid rollout, including the populations Jose just talked about, saves between 44 and 49,000 lives. And that's just at April the 1st. The tipping point is really, as we saw on the graph, after April the 1st, there's a tremendous drop off if we have a rapid rollout. If not, we're still messing with this thing in May and June. And, I think we all want to be together for the 4th of July. And there is an absolute way that could happen if we stay on course with a rapid rollout.
The CDC, Dr. Fauci, is pretty public. They've all said they need about 80% of the people vaccinated, as you mentioned, Dr. Myers. Is there any other way to get to, quote unquote, herd immunity without this vaccine? Because we hear that term a lot as well.
Not without a bunch of people who are dead.
That's right. If you go to the University of Washington model, the last run to get there is about 250,000 more deaths at a minimum. So you can get there in one of two ways. You can open the gates and let's all go run in the street like an old chicken pox party, if that's what we want to do. and kill 250,000 people extra, so it'd be 800,000 plus, you know, at the end of this thing, or we can all go get a vaccine.
And right now, as of this morning, I believe we're at 300,000 deaths already, or we're pretty much in that number. So just to give that context, how many more deaths you have to, you know, suffer to be able to achieve that level?
So I want to touch on the safety aspect of this. I think one of these companies took money from the government. I think Moderna did. I think Pfizer self-funded their vaccine program. Obviously, that means they have a lot of money tied up into it, which means they need this to be successful. Does that give any of you pause in the fact that one took money from the government and one didn't, and there could be the possibility of quote unquote fudging the books or the numbers?
No. Yeah, so it's a great question, right? So, and I'm, you know, not going to go too far into this but this is one of the things that we talk about, right? When we do journal clubs at Callback, or when we talk about, you know, how to evaluate research in the academy, we talk about evaluating the nuts and bolts of the study, right? And, you know, who wrote it, and how old is it, and all those things. And one of those things that we talk about is who funded this study, right? Yes, that is a important piece of information to know when you evaluate science and research. That said, medicine broadly, and certainly emergency medicine and certainly vaccine science, would not be nearly where it is today if you didn't have funding from the government, funding from big pharma, funding from drug companies, right? That's how you know, science is made, frankly, is by having the money to do it that comes from all these different places. So I think it is perfectly reasonable that the funding either comes from the government or comes from big pharma. And yes, do they have an incentive to make it work? Of course they do, or they wouldn't have tried in the first place. The other piece to say about that is that, and you can evaluate this just by looking at both the Pfizer vaccine and the Moderna vaccine. The technology, as we've already said, is very, very similar, right? The differences in the two vaccines are probably some proprietary, how do we stabilize the liposome at, you know, -8 bajillion degrees versus -2 bajillion degrees, right? The technology is very, very similar. And we see that the results to this point are very, very similar, right? With two separate funding sources, right? One being the government, one being private industry. So to me, the science of evaluating these different vaccines, and especially as we see more about Moderna, we see more about AstraZeneca and Johnson & Johnson, will tell us that the data are legit, right? Even comparing the vaccine results across companies, right? So comparing them internally, as well as understanding how science funding works in general, none of that gives me pause in terms of whether to believe the results or not.
And I would add to that that Jeff's comments, which I agree 100%. So the funding piece to me, and it's a reflection of companies that may need more resources than another one to be able to respond to the calling from the government about we need a vaccine and we need it by tomorrow, right? And this is an unprecedented response from scientific space and pharma and all these companies to a very unique moment in time for the world and the country. So the what gives me a lot of reassurance is that whatever mechanism we got the resources to develop and evolve the science, we've known already established technology, is the fact that all these studies have to be vetted through a established process that has been there for many decades to vet this kind of you know, new pharmaceuticals, new vaccines. So they were developed, but they had to be vetted through the FDA EUA process, which actually makes me feel very reassured that you know, third-party experts are looking at the data, and we're not just, you know, taking it for granted that somebody said it's okay to go.
Just Don, to put this in that historical context as well, I'll get you this article, but there's a great description of the day that both companies decided to sign on, right? And Pfizer, in the true libertarian sense, said, I do not want the government interfering with the steps of my process. I don't want the money. I want to do this myself. Moderna had 800 worldwide employees the day they got $2 billion from the federal government. And as a little startup said, by God, we're smart enough and we're going to do this thing. And giant Pfizer and little bitty Moderna came to the exact same conclusion within a week of each other. Tells me that the data are pretty good.
So we know that one of these has to be kept super, super cold. From a safety standpoint, does that add any increased risk? Are we confident that people are going to be able to handle the vaccine and keep it within this tight temperature control so that the virus is in fact effective?
Yeah, that's a great question. I am reassured by the fact that the first as we are recording this talk, the first American was vaccinated, right? That comes very shortly after the FDA said, you guys can begin shipping this thing around the country, right? So to me, one of the amazing things that we frankly need to give credit to the government for, and certainly the drug companies, is the logistics, frankly, the support services processes that have backed this whole thing, certainly since last week, and obviously in the months of preparation ahead of time. So, and then to be specific, there's a reason why the vaccine is only going to 10 or 11 or 12 places on day one, right? And more places than that on day 2 and day 5 and whatever else. And that's because those places have proven to the government, to vaccine manufacturers, that they can do what's required, right? They have the cold storage necessary, and they have designed a process to keep it safe and to do it appropriately, right? The vaccine isn't just getting shipped willy-nilly everywhere. It's only getting sent to the sort of hub places that have proven that they can keep it as cold as necessary. So I'm reassured by, frankly, the proof in the pudding at this point on the logistics side and the shipping side.
And this and some of these containers that they're shipping all these vaccines, they have temperature monitors, they're sealed. I mean, the amount of infrastructure around it to be able to safely and effectively sort of deliver from point A to point B in that environment is pretty impressive. I mean, if you look at some of the pictures out there and whatever they put out, it's pretty impressive, the level of sophistication around the containers to be able to ensure that constant temperature.
As you all said before, this has been a rapid turnaround. What about long term? 3 years, 5 years, 10 years down the road? I think several of us have seen the movie with Will Smith, where he thought he was creating a cure for cancer and turned out to give everybody rabies. Do we have any long-term concern about vaccines causing, I don't know, heart disease or cancer or whatever it could be?
So the direct answer to the question is, there's absolutely no way to say that for sure, right? Let's be transparent, right? I mean, we have had these vaccines in studies since July, right? And it is now November, early December, right? So we can't say this with 100% certainty. What we can say is that we know how these things work. We know they aren't persistent, right? I mean, basically the vaccine comes in with these little liposomes. It stimulates your endogenous system to make a protein for a short period of time, and it's gone. So is it remotely possible? Yeah, that's probably true. The analogy I go back to, and I hope Olson's watching this, because there was a crash review board, right? That long time ago, when I was the director, there was an ambulance that crashed in the snow, and a member of that crash review board said it's a preventable accident. And we said, well, how is it preventable? He said, well, you just didn't have to go. Well, okay, yes, we can assure that there's no complication from anything if we do nothing. So, but I think we've got to go, right? And so we've got to take the best data that we have, which says this thing does not persist. We know how it works. It's been around for a long time. And can we say with 100% certainty? No, but we can't say with a 100% certainty a lot of things.
Okay, so again, staying along the safety argument discussion, we know that shortly after Pfizer began administering their vaccine, there were several people who had some allergic reaction. And we also know from AstraZeneca that there was a dosing error or problem back in November where several of the participants actually got lower dose of vaccine than what they were supposed to get. You know, again, I go back to how confident are you that these vaccines are safe and are going to do what everyone says they're going to?
So I'll take that one just to start off. I mean, I think that what reassures me is the massive number of people that have been studied in both trials, right? And I think that overwhelmingly, those trials have suggested that the vast majority of people are going to be safe when they get the vaccine. Now, certainly, as I mentioned in my portion before, you know, bad stuff happens to people whether or not you get the vaccine. And it's certainly also true that there are single numbers of things that have happened to vaccine participants that are probably vaccine unrelated, right? Whether that's a hypersensitivity reaction, a handful of people in both arms actually, you know, had various and sundry adverse events. And, you know, whether or not you can attribute those to the vaccine or not, sometimes an extraordinarily small number, extraordinarily small population is unknown. But the dramatic great majority of people who had these vaccines had an appropriate, safe response, right? So is that to say that the next person who gets it, you know, won't have an extraordinarily rare complication that's possibly attributed to the vaccine? No, I mean, yes, just like Brent said, you know, something like that can happen, but the numbers suggest that the chance of that happening is extraordinarily small.
The other thing, Don, just that gives me reassurance is, yes, you mentioned AstraZeneca. Where are they? They are not submitting an EUA, right? So the EUA process is incredibly robust and incredibly thorough. And so people that have made errors in their studies or have some better data they need to do or reanalysis, they are not submitting an EUA. So if you've got an EUA, that gives me a great deal of confidence compared to those that are in, you know, pre-EUA stages.
And finally, my last question, and while this has not come up as much as it did historically, I do want to give everyone a chance to sort of answer the question. Vaccines do not cause autism. Is that a true statement?
That is a true statement.
That is a true statement, yes.
That is a true statement. And by the way, neither do power lines cause leukemia, just so while we're there.
All right. Excellent. Well, that's all the questions I have. Quickly, we'll go around the horn. Dr. Myers, you're getting the vaccine. There's no doubt in your mind, and you recommend it for everybody.
Absolutely, 100%.
And Dr. Williams, same question to you. You're rolling up your sleeve. You're getting the vaccine, no doubt in your mind.
Absolutely. There's a race to compete to who can get it to me first, either the county or the hospital.
And Dr. Cabañas, you're getting yours as well, I take it?
Yes, sir. Right here.
All right. Dr. Cabañas, I'll give you the last word for today.
No, thanks so much, everybody, for being here today. Thanks, Brent and Jeff and Don. Thanks for putting this together and getting us all in the round table. Again, we are in the critical stages of our pandemic response in our country, in our community. And again, like I said in my opening, I cannot thank all of you for all your hard work, dedication, everything you are doing to serve our community, and especially your patience of being flexible and adapting as we have made changes since March the 3rd when we had our first case, adapting to our PPE, adapting to our response. Everything you are doing has been incredibly valuable to make sure our community is safe. So now at a critical stage of the pandemic response, it is critical now that we all participate in this vaccination process so we can make a big turn on the corner, prevent additional growth in our curve for deaths and more cases. So again, I really encourage all of you to take vaccination. If you have any questions, concerns, things that come up, please feel free to reach out to any of us because we want to make sure that we're giving you all the information you need to make your personal decision.
Excellent. Well, thank you all for taking time out of your busy schedule to join us today and answer all of our questions and give us, again, the straight, honest, backed, researched information about all these vaccines. Again, as Dr. Cabañas said, if you have questions, please feel free to reach out. If we get enough questions, we may decide to do another one of these videos if we need to. Thank you for tuning in, and please be safe out there.